Good afternoon, everyone. While the panel gets situated, I know it's the last panel of the day and some of you are probably starting to zone out, so I'm going to make everyone stand up. Okay. So everyone who has hair that is shoulder length or below, go to this side of the room, and everyone else go to that side of the room. Can move around, wake up a little bit. Figured that's the easiest way to divide since it's a clear, decisive line. Okay, great. So you're probably wondering, and you can sit down, you don't have to stand, unless you want to. So you're probably wondering why I decided to divide the room. And the reason being is that this panel, which is going to be the most interesting panel of the day, is here to discuss the integration of specialists in primary care in value-based arrangements. So this side of the room, you guys are the primary care physicians. This side of the room, you guys will be considered the specialists, and I did that for you, Lanny. Okay. So with all of the changes in healthcare over the last decade, you would think that we would have a lot more integration and collaboration between primary care doctors and the specialists. But no, we have this big wall between them. So we know that the collaboration, if you guys were to collaborate, you would have better outcomes, reduced costs, and you have greater access to care for patients. So the question I think a lot of people are asking is, why hasn't this happened yet? And the panelists that we have sitting here today, we're going to delve into that. But before we do, I think it's really important for each of my panel members to give a background on their companies and what they do on a day-to-day basis. You have what's in the pamphlet, but they each really have a unique set of expertise that I think will lend itself to having a great in-depth discussion of why it's taken us so long to even get to the starting point of integration and where we really see it going. So Kelly, would you start? Would you introduce yourself? Tell us a little bit about Pinnacle and kind of what you do on a day-to-day basis.
Sure. It's interesting that there's all gentlemen on this side of the room. All females on this side of the room. My name's Kelly Conroy. I'm a principal at Pinnacle. I focus, do this every time. I thought it was on. I like to focus on starting accountable care organizations. There's many people in this room that have started the first ACO. Lanny wrote one of the first application. So I like to start ACOs. And what I realized as a consultant with Pinnacle, that outside of Florida, there are very few ACOs in rural areas. So I've decided that I really want to go to those people and help the people in rural areas. They don't even know FQHCs, RHCs, CAHs, they can all be in an ACO. They're all doing this special kind of work. They should be paid for it. And the second thing that I really like to focus on in my practice of consulting is integrating specialists in primary care. I was blessed to be part of the Palm Beach ACO startup, and they started with 100 primary, 100 specialists. I have not come across this in the country. I really have not come across ACOs that have specialists in their startup from the beginning. So just love to do that type of work. Pinnacle has been doing this sort of work for 20 years. They do a lot of transactional work. They do a lot of valuation work. So it really lends itself to really good partnerships. So we spend a lot of time with health systems. I like to really focus on fiercely independent physicians. That's what we did at Palm Beach ACO, is we harnessed that power, and I love to spread that information across the country.
Thank you, Kelly. Jeff?
Well, I think everybody kind of has an idea of what I do already, but with Influence Healthcare, what we're really looking at is working with the specialist providers. And, I probably should make the point that there's a difference between specialists. So we're focusing on surgical specialists as a start, really spine surgeons, orthopedic surgeons, and then from there expanding out into cardiac and then some of the other spaces. But the focus is really surgical. And I think within primary care, you also have specialists within the primary care side. When you're a surgical specialist, you kind of think of everybody else as primary care, although there are, specialists certainly within that area. So our focus is that we build new value-based care contracts that reflect the surgical cases we do instead of the codes and the CPT codes and the DRGs that the government has come up with, which don't typically match up to the cases that we do. And then we look for ways to incentivize the surgeons to lower those costs by making decisions that will still preserve quality, maybe improve quality, but really about lowering costs and very simple decisions that we make.
And Robert, everyone knows where you're from.
Sure.
But tell really what you do on a day-to-day basis.
So on a day-to-day basis, I think it's a matter of evolving and really working through a path. Our company has evolved over 11 years, starting out in the analytics space. It was called Aver Informatics. Actually started in Green Bay, Wisconsin, so started in a very cold place, and moved along and then moved into and evolved into really looking at data and analyzing that data, initially for potential fraud and abuse and being a source there, but then started coming at it. So we came at it from the specialty side, not from the primary care side, and started looking at ways that you could do episodes of care, bundle them using methodologies that do that to figure out what's in, what's out, primarily with the focus on payers and helping them structure arrangements with providers. Along the way, there was a conversation this morning about can't versus won't share data. I'm a little bit cynical. I was a practicing lawyer, so I'll go with more won't than can't, but that's another story. So we looked at it, we said, well, you really need to drive this all the parties and looking at the total care of someone. And so you really do have to drive both sides of this equation. So reaching out, creating a value-based entity with the help of Ed and Mike and the Nelson Mullins team to go out and start to build and work with folks like Jeff on the provider side to bring together. And it's sort of an analogy of any network. I've been in the networking space a long time. So if you think of Airbnb or you think of Uber or you think of eBay, take your pick, right? So eBay's the easiest one for me. There are people that wanted to sell stuff and there are people that wanted to buy stuff. And they were out here and they didn't know how to find one another. So eBay put this system in the middle to allow them all to gain trust, talk to one another, exchange money, exchange goods. And so we're really trying to facilitate this. And that's really led to having, one of the first parts is you got to go to the quarterbacks or the primary care, figure out how you integrate them with the specialist. Your point about why hasn't it happened? I mean, I have not spent 30, 40, 50 years in healthcare. I've been in the payment space and the networking space, but I can tell you that I think the number one primary culprit is fee-for-service. I mean, just the way it's set up does not lend itself. I mean, if I look at, and everything you heard about today, right? So fee-for-service is set up so that specialists do what they do, primary care do what they do, and never the two shall meet, so.
Okay. So, Robert, you mentioned fee-for-service as being one obstacle. We've talked a lot today about the change in regulations and those being an obstacle. And Dr. Thraman, you touched upon that earlier, right, when you were talking about your obstacles that you have had to encounter and divest certain business interests because of certain lack of flexible regulations in the past, right? But there's other reasons that this hasn't happened. Dr. Thraman, why else, in your opinion, do you think that we have not seen the integration in addition to fee-for-service and in addition to the regulations? Are there any other things that you're seeing?
Well, I mean, those are the big ones, right? Because they immediately create a non-starter, but it's also it's a difference in the patient that you see. So the way the patient's journey is typically to their primary care doctor first, with whatever complaint they might have, unless it's really obvious, what the problem is. They're typically going to their primary care doctor. The primary care doctor has a tough problem because they're seeing the patient sometimes for the first time in years because they haven't had an issue, and they're coming in and they'll run a series of tests. They typically don't have studies that they can look at yet, and then they'll run these tests and they'll look at some odd results, let's say, and then they wind up with what we call a differential diagnosis. And every doctor starts with a differential diagnosis. The difference is with a primary care doctor in an otherwise healthy patient, that differential diagnosis is going to be really long. And there's going to be a lot of services and a lot of studies and a lot of workup that has to be done to understand what's going on. As they start to dial in with that and they come up with a diagnosis that's going to require specialty care, well, then they send them to me. So I kind of started new at that point, and their past medical history, a lot of the stuff that's been worked up, all of that's been worked out for us. I'm looking at essentially a film. I have an exam, and I'm talking to the patient, and I make most of my decisions based on that. And if there's going to be a surgical decision, then I'll make that surgical decision. All I really do with the primary cares is I will sometimes call them up if I know the primary care doc. I'll let them know what I'm thinking and what I'm telling the patient. Otherwise, the record just goes over to them. They get it. They can read it or not read it, depending on what they do. So there's not this huge discussion. Now, are there things that we could do where we could work together to streamline that? Certainly, but the system really hasn't been set up for that as of yet.
And Robert, you have worked for many years, right, on the data analytics side. How do you see that as playing a role in the slow move to integration?
Well, I think that is, I was going to say, beyond the fee-for-service and the regulations, the data is the key. And again, if you go back to some of the big networks that are out there, it's this ability to take data from one side, the provider side and the payer side and the patient side, and put it all together. And then, number one, share it. And number two, one of the comments earlier today was around intellectual property and ownership of data. I actually don't think that's a good idea. I think that the serving the patients and getting better outcomes is the idea. And, I've been around way too long. And in the early days of the internet, one of the reasons it took off is that everybody agreed that they would use TCP/IP, this standard, and everybody would go to this standard, and that facilitated exchange, and everybody could create value around it. The Linux operating system was open source, but Red Hat Linux made billions because they just gave it over to the standards, and that way everybody could share and add to it. And it didn't become about, it's my data, we got to use Epic, we got to use Cerner, we got to use this. Let's all share it, and then everybody can add to it and benefit from it. So I think there's number one, just the sharing of data, because it's not a trivial exercise to ingest data to be able to then analyze it. So in a consistent fashion. So I think the data exchange and then the ability to interoperate around that and create more standards is a huge piece of it as well. I'd be curious what you all think about that.
So Kelly, I know that when we first met, right, it was in connection with your operating Palm Beach ACO, right? And then dealing with what data did you have to try and figure out, what is our patient population, right? Because that was so integral in being able to generate shared savings. And so I would think that there had to be certain policy issues from that time period when you started that kind of created a culture that created this sort of, I don't want to say animosity, but a divide between primary care and specialists that made it less of an incentive for them to work together. Would you agree with that?
I would agree with that. And just to expand on that a little bit, from doing this from 2012 till now, what I'm titling War of Attribution, it's a thing. It's a real thing. So in the early days, we had to learn how the patients were even attributed to the primary care. And it turns out it's about how often they see their primary care. But as time has gone on, people didn't realize that every single quarter, your attribution would actually get updated. You would see like a 1% change, but really 300 patients went out and 299 came in. So how can you possibly work on patients if they're changing every quarter, right? So as time has gone on, the government has continued to make these regulations, and I don't know if it was Gabe that said, or maybe, I forget, somebody did say that the government really does want this to work. I remember going up to CMS and they said, listen, we don't get shared savings if you don't get shared savings, and the whole point is we're trying to bend the cost curve. Unfortunately, the way they've established these attributions, for primary care, which really gave the primary care a nice seat at the table. Now I almost feel like they are the table. But we then started to disenfranchise the specialists, right? A lot of people thought, well, you'll just be part of us and we'll send you our referrals. That didn't work at all. So then the government came out and said, well, let's start an oncology practice. Let's start a whole bunch of kidney care practices. Again, war of attribution. If you have kidney care, you may think they're in your kidney care. The ACO thinks they're in the ACO. There's really not a lot of communication going on between the two because everybody's trying to be successful in their program and take care of the patient. So in the government's infinite wisdom and the unintended consequences, I feel like they're even siloing the specialist even further apart. And so what we're all here today to do is find those resolutions and answer that question. How can we stop breaking these patients out? And how can we put them all together and work on them in a whole person sort of a way? So that's what we're looking to do and solve. And I'm looking for anybody in the audience that wants to help me because I am taking, and I will tell you an example of what we're doing, but I'm taking this solve or this solution to CMMI because they don't know the answer. It's evident that they don't know the answer, and their next 10-year strategic plan states that they want to have that answer. So
Do you have any thoughts on what you want to propose?
I do. So I'll talk about kidney. So glad you asked, Heather. It's like we talked. So what I propose with kidney care, because it's a really big problem. I mean, the kidney doctors are trying to take care of the patient. I think what Dr. Thraman's doing is amazing. And look, he's been innovating for how many years, and the system has been stopping him at every corner. So super exciting that we talked about value-based care entities and anti-kickback safe harbors, and now he wants to make it simple and just have doctors talk to each other. How great is that? So on my example with kidney care is, what if they're in an ACO for a while, and the rules of attribution are if they're CKD 4 and 5 and end-stage renal, and they see a nephrologist twice, then they go to this kidney care ACO, so to speak, and nobody really knows who. So what if we came together in a VBE? Oh, Heather, can I show my little umbrella?
Sure.
If you could find it.
Slide.
What if we all came together and we said, okay, when they're CKD 3 and under, the primary care takes care of them and they get the bulk of the savings. But the specialist gets a part of that savings as well. And then when they go to CKD 4 or 5, it's one more right there. When they go to,
Back?
no, back one, little umbrella.
There you go.
When they go to CKD 4 and 5 and end-stage renal, then the nephrologist gets the bulk of the savings, but the primary is still kept in because they have other things wrong with them. And, just if we're never going to get quality, and that's what we really need to focus on, if we don't get these doctors working. And I believe that's why the government threw this program at us in 2012. And for those of you who were around in 2012, they literally threw the program. They didn't have the answers when we called, and they continue to make changes, good changes, but they're still stuck. So I'm super excited about this value-based care entity. I feel like it could be the umbrella. What I'm showing on the screen here is, you have ACOs, you have CKCC, clinical integrated networks. What if you had post-acute, like ambulatory surgery centers, imaging centers, all kinds of stuff that the doctors could actually own and they can all benefit from and they can all get comfortable with each other. And talk about a closed loop of the continuum of care. I mean, everybody could have point of care decision-making stuff, and of course machine learning and AI is going to really play a vital role in that. So you probably noticed that I labeled MSO services as value service organizations. So, for those who are really on this value journey, I think VSOs can support the VBEs. We can have multiple partners, but gone are the days where you can't refer to each other. And I remember very early, and I keep looking at Lanny, and I don't know if Kirk's here, but we said if we can't work with each other and refer to each other, how's this ever going to work? We have to refer to not only that, but you have the problem that the patient has choice. The patient can go anywhere they want. So if we could create a value-based care entity, kind of remove all those legal impediments so that people like Dr. Thraman can innovate, and it can really innovate. I mean, we could, and I love also what you said is, let's stop trying to fix this very broken system. Let's build it. And I think the VBE might be a good way to start tying it all together.
I think one thing you point out that I would add too is that, and Juliet talked about today how really value-based care is a payment. It's about payments. And I think in addition to not allowing Dr. Thraman to be able to own a piece of this or get profits from that the path of the money just has got to be, it's got to be flexible so that it can fit these as well. Because if you listen to some of the conversations about, they're at-risk primary care ACOs that are getting a PMPM to do the total cost of care, and the minute they hand off somebody to a specialist, 90% of what's impacting the profitability of their organization just walked out the door, and they don't know what happened. They're blind to it.
Yeah, and I think that's a key point. And how this whole thing overlays is that, with the specialist, I don't see there being this, or having to be this big change. I look at, as a surgical specialist, I tend to look at the primary care folks as the folks who have always managed the patient until they needed us. And the big change that I'm seeing is you're just seeing more of these primary care docs go under a capitated system, essentially. So once you have a capitated system, now all of a sudden, if they're at risk for the full care of that patient, all of a sudden the primary cares, now they care about who is the specialist that I'm sending this patient to. And I think now you have the specialists out there, and there's some variability on specialists. Some guys are going to go and learn additional techniques. They're going to try to push the envelope, and in the spine world, let's say, they're going to adopt new diagnostics, or that might give them better results. They're going to look at more minimally invasive techniques and try to push the envelope there. And some guys won't. Some guys want to they're going to keep doing what they do. They've gotten good results in their minds, and they're going to stick with that. So let the data show who's getting the better results. Let the companies or the physicians that want to take a lead on the specialist side, let them go into these value-based enterprises where they can make the decisions and do the things that they need to do to lower the cost while maintaining the quality that they're able to deliver. And then let the primary care docs, let them decide who they want to work with. They're the payer at this point, in my mind.
Yep.
And we need to service them or provide them with a product that's going to get the better results. And that's kind of how we're trying to set this up and work directly with those payers that are out there, or with the primary cares that are taking on that risk.
There are so many things that were talked about today that kind of play into what you just said, Dr. Thraman, right? You're talking about data, right? And one of the things that I think Juliet said earlier is, what is the data, right? Is it garbage? If someone said, is it garbage or is it real, right? What data are you using to analyze? Where are you getting it from, right? Because the value of the data that you're using for your analysis is key to whether or not the venture is going to be successful. So, Robert, where do you get your data from?
So again, historically, when we were representing payers, we got the claims data from the payers. So that was where it came from. But if you start to look at different, if we're looking at more government-related plans, you're getting CCLF files that might have certain things in it, but again, you might not know how many members they had this month. So how do you start to analyze that data? So it's different data sets and it's different ways it's coming in. So you spend all this time trying to figure out that before you can, A, determine if it's garbage or not, and B, determine if you can actually run some analysis off of it. So.
And then you obviously need that analysis then to educate the providers as to where they're losing money, right? I remember, Kelly, when you started, it was, okay, what's our lowest hanging fruit? And you were able to save money that way. But, right, that was years ago. And now we have to be a lot more advanced and strategic on how we have cost savings and how we collaborate. So, one of the things we talked about, right, we're talking about data, and then what do you do with the data, right? Now that you're able to have a data set that you can work with, and there are probably some gaps in it.
Yep.
One of the things that Dr. Thraman said earlier is pushing knowledge to the specialists, right? It's, okay, we now have to push this knowledge to the specialists, and we probably also have to push it to primary care. So what are your thoughts on that, right? You have doctors so busy, they don't have time for the admin work, right? They don't have time to sit and do a lot of things that would help them get to this next level. So what would be your words of advice to both primary care and specialists as far as, or I should say to the groups or to the health systems in pushing this knowledge down to the providers?
Well, I mean, that's the whole thesis of Influence Healthcare. It's really we want to pay the doctors more for doing more, for paying attention, taking care of the patients, focusing on new technologies, looking at the data, documenting the data, and just being more involved in the overall care episode. Right now, I get paid for one thing. I get paid to cut. Right? I'm going to cut. I'm going to do my case. I'm gone. That's all I got paid for. And we're capitated. We're covered 90 days. If I have to go back in, or if I have to see that patient in the office or the ER or anything else, I'm not getting paid again. Right? That's what I do. And I go in and I do that. But I don't document outcomes. I don't follow up the patients with imaging studies or ODI or VAS. I don't report to anybody what the clinical outcomes are. It just does not happen. And there's no mechanism for doing that. But on the clinical research side, like we're proving the efficacy of a particular product, we do this, and it's not that hard. ODI is not a hard thing. That's a validated clinical reference model that you're going to see in all the clinical literature, right? And all the clinical literature that gets published out there, all the surgeons out there, and I'm sure this is for all doctors, we have a thing called Journal Club, where when you're going through your training, you sit there in a room and you get assigned the articles. For me, it would be Journal of Neurosurgery and the other journal, which was Neurosurgery, and then there's another one called Spine. And we would be assigned articles. We would analyze those articles. We would go in and we would look at the methods. How are they getting people into these clinical studies? How are they running that? What's the bias between the groups? Is it a prospective randomized? Are they blinded? What are all the issues here, and what are the statistic metrics that they're using to analyze this data and to come up with ideas about outcome? And I can tell you, in 7 years of doing that in my residency, we're looking for one thing. We're looking for a study, because we finish every presentation with, will this change your practice? And I can say, I think in the 7 years of my residency, and don't quote me on this, but it's something like 3 papers changed the way we would do things. And it's just because of the way that the data comes in and the size of the studies and just getting publications and what that does. But when you expand this to, let's say, a value-based care model like this, and you have a value-based enterprise where the surgeons are doing more, and part of your protocol to get paid more money because you're cutting this money out of the overhead that's in the specialty hospitals, that's at the ASCs that the vendors have, and you're documenting, what are my outcomes? What are the outcomes for every one of these patients on these validated forms that people put a lot of time and effort into developing over centuries and have been validated over and over again? It's what the FDA looks at in every service or device that gets approved. And you're doing that as part of your clinical practice, and that's being tracked. You're going to start seeing pretty quickly where the value is and and the things that are working and aren't working. But it all starts with, how do you change this? Right? Because to change behavior and to get a busy doctor to do something else, you have to pay them more, right? And what's the value in paying a doctor more to do better with their patients? How do you compare that to $1 million salary for the hospital CEO or a $750,000 salary for the COO? I don't need those guys. I really just don't need them, right? They're there because of the administrative burden. They're there because of the reporting that they have to do, but they're completely of no value when it comes to providing patient care. So that's what we're doing at Influence Healthcare. We want to eliminate that, and we want to take it back to the doctor, get back to that thing that I talked about in the very beginning. It's a patient sitting down with the doctor, coming up with a plan, and going to execute on that plan with the least amount of obstacles in our way as possible. And that's what we're going after. And the data there is going to be phenomenal.
So you mentioned, will this change your practice? And that was, a focus. And so there's a lot of things that are going to have to change from the way that doctors traditionally practice medicine, right, to work toward this change and work toward, this integration and creating this value in a way that will be profitable and worthwhile for providers. One of the things I wonder about is, and Robert, I'll direct this question to you. How do you view specialists as losing in this relationship if they don't integrate with primary care? They don't change their practice.
Well, there are a lot of, the first two words they teach in law school is it depends. There's a lot of variables in there. I think as I look at our mission, I'm looking at this picture on the slide here. We kind of want to be that umbrella. We want to be that sort of Switzerland in the middle that helps facilitate all this. And our hope is that if you facilitate this, then with the providers, you can explain to them, and she or he can say, okay, I see where this is better for my patient, this is better for my bottom line. And so you can do both the cost and the outcomes. And then you work with the payers and you say, here's where it's better for you, and let's all work together with the common that we really want this to be better and more cost effective for the patients. Move us out of that lower right and in the chart that Juliet showed this morning. So I think that it really starts with, again, kind of not as an advertisement, but we kind of come in, we'll design a program, we'll analyze the data, we'll help implement it, and we'll help administer it. So you got to give people the tools. Again, if you go back to the Airbnb example, there's got to be some app that you sign into to find out what places are available and how much it costs, or a travel agent. There's got to be something in the middle that facilitates all that. So I think that's a key piece of it, and don't mean that to be self-serving, but it is a critical component of it. And then you have to find people like Jeff who really see the wisdom in this and will help explain. I can't explain to the doctor groups the way he can the value of this. And so partner with him, and then he can go explain to the providers why this makes a lot of sense. Partner with Kelly. It's about kind of how they can go in there and help talk to their constituents about how this will work better. So I think a lot of it does come back to we, the pioneers, and working with the Nelson Mullins teams. It's not lawyers telling you why you can't do something. It's lawyers trying to figure out how to enable you to do something that's new. So you guys are a big piece of this. But then I think everybody's just got to. It's in the early days of the internet, it wasn't a negotiation to see who's going to win the negotiation. It was, we want to do online payments, and you want to do online payments, so let's figure out a way to do it. I've got an ATM card. We were talking about this morning. I've got an ATM card, and it works great if I'm at my bank. What if I'm out of town? What if I'm in another bank? So Plus Network, Sirius Networks, but it comes together, and now my ATM card works at a lot of different places because competitors came together, or perceived competitors came together, and they worked together to have a framework that would then the rising tide would lift all ships.
So Kelly, I know that, a lot of your work has been in the primary care space, now more so in the specialist area. And when she first started, there was really a resistance with the primary care physicians to work with the specialists. In your experience, how do you think that has changed? What do you think caused the primary care physicians to start being more open to working with the specialists?
I think risk. So as the government has pushed everybody, ACOs started out as track A, B, C. They were no risk, just to get everybody in. And for the last decade, we've turned the ship a little bit, right? And a decade is fast for Medicare. But as they've pushed us along the risk, the primary care doctors know if they don't include the specialist and if the specialists don't help, it's not going to work. So I just wanted to go back 1 second, though. Like on this umbrella, I feel like the top of it is information. That is the problem for everybody. Nobody has the right information at the point of care. And, Dr. Thurman, I love when you said just sit down with the patient and make a plan. If the PCP and the specialist could sit down and have the information at the top, the technology, we cannot rely on claims data at all. I mean, there's one major player in one of the BUCAs that gives you claims data 266 days later. So how's that help, right? So just getting that claims data together and having the conversations. And I think that since most ACOs, and I talk about ACOs, but I want everybody to know, it's the same concept for Medicare Advantage, CINs, whatever alphabet soup you want to label it, anything that's risk-bearing. Pushing the doctors to have to take risk, or anybody to take risk, they have to include the specialist. And the worst thing, well, maybe it's not the worst thing, but in the ACO reaches, they basically went out and said to all the specialists, can you give us a 5% off your normal fee for service so it can drop straight to our bottom line? And the specialist's like, No. Glad they're introducing a new radiation oncology model that I'm going to jump into because, they're just a tiny fraction. So I think everybody here has mentioned aligning incentives, super important. At Pinnacle, that's what we're doing. We work on it all the time, is how do we align incentives appropriately so that we can continue to give the patient whole patient care. And the last piece I just want to mention is patient engagement. We always seem to forget about that. We've been trying to get to that point since the beginning of time, but we always seem to forget about it, telling the patients what we're doing, and they would help us. And I think if we can do some of those things, the patients will have a much higher value visit, they'll be engaged in their own health care, and we'll close that loop for continuum of care. Everywhere I go, I hear gaps in care. We need to do an annual wellness visit to close gaps in care. I'm like, how about if we just took care of the whole patient? And so basically we're checking a lot of boxes, and I feel like whoever's on the top of that umbrella, the information's there, they can check the boxes. Everybody in this room could attest that every single insurance payer has a shared savings component, and every single one of them has different quality measures. So how are we ever going to improve quality if all we do is check these boxes? And I think maybe we are starting to get closer to a solution. Was that an answer, Heather? Or was that too long?
It was an answer to multiple questions.
I know,
so thank
sorry.
you.
I was afraid I wouldn't get to talk again, Heather.
Well, I'll give you one more opportunity.
Okay, thank you.
Okay, so before we wrap up and get to Q&A, I just wanted you to maybe shed some light on one more thing. So CMMI has a 5-year strategic plan. And I wanted you to discuss, you guys are talking about plans, so I thought it'd be appropriate. If you can shed some light on how discuss a little bit about the plan and then how you think that will impact the integration between the PCPs and the specialists.
Okay, can you give me one more slide? I think it is the CMMI. Yep, one more. There it is. Okay, so everybody probably in the room knows that CMMI stands for Center for Medicare and Medicaid Innovation. They're the ones that got the $1 billion in 2012, or actually 2011. So they had a 10-year plan. This is their new 10-year plan. You can see it says, you can see that it says they want everybody to have an accountable portion of their payment by 2030 for accountability and quality. So they still have on their 10-year plan accountable care. I don't know if it'll be called ACOs. I don't know what it'll probably always be called Medicare Advantage because it's been around for a while, but it's going to be accountable. Advancing health equity, that's a really big buzzword in this time frame. But for me, I see that as access. Give the patients access. The people that can't get transportation, the people that they live in a food insecure type place. Advancing health equity, I think, is going to be access and getting people to the doctors. This is the biggest one for me, is support innovation. This is what Dr. Thraman's doing. This is something that they put an obstacle for doctors to do for such a long time. So they really are centering their next decade on innovation. They don't have all the answers. They're giving us more data than they've ever given us in the last decade. They're even giving us models that we can do our own projections from the data. Addressing affordability, that's been the whole point of this. This whole thing falls under the Affordable Care Act, right? So it's always been about addressing affordability. And then lastly, it's about transformation of the practice, right? Nobody wants to do this for their Medicare population. Maybe your Medicaid population is 20 or 30% of your practice. Nobody's going to change behavior for 20, 30%. So we need that denominator to be 100% of the patients you practice on. And we are taking one big step ahead on that because we're doing quality measures for your entire denominator in the next couple years. So I think, how do I think this is pushing them apart to bring them together?
Bring them together.
I think the innovation, I think the value-based care, everything we've heard about today from Nelson Mullins about value-based care entities and reducing all those barriers of Stark and anti-kickback, I think that's their signal. Like, we don't know how to do this, but we're going to give you guys a lot of ways to innovate. And I think that is going to bring specialist and primary care together.
And I think also one thing we didn't really touch upon is the fact that you have so many innovators and aggregators and, a lot of non-traditional providers in the market, right, as we talked about earlier. And the reality is that you have the primary care savings, but those are getting smaller and smaller and smaller. And these new players in the market are always looking for ways to innovate and earn more money. And I think that they are going to be the ones to start pushing this knowledge down, creating the plans, right? They're the ones that have the money to invest in the infrastructure. That might put a little wrench in the autonomy aspect. So I think part of it, right, Dr. Thraman, you mentioned earlier, one of the goals is to try and keep physicians autonomous, right? And so we're going to see that struggle, right? As there's more consolidation, the constant flips in all these businesses, and the need to generate more money, right? How that's going to play out over time. I think we're now at the point where it's Q&A. I know it's the end of the day and most of you are probably tired, but anyone that asks a question gets candy. And I have some full-size ones in here. All right, Lanny.
So, first, I think I'd like to make one sort of a distinction. Dr. Thraman has been talking about specialists, and most of his words are about surgeons, and I think he sort of made that point today. I look at this as primary care was who everybody went to first because they see every patient. May not know everything to do, but they see them. And the surgeons are coming into it because they do the high-cost things, and it's once patients are sorted and get in front of them, they either get better or they don't, right? You do the surgery or you don't. The thinkers in the middle, who are the specialists that I represent, are the ones that are left out. They're the ones that don't know how to get in. And I think one of the shortcomings that I've seen so far are there's not been anything that's engaged them to come into work, and maybe some of the new things on CMI, whatever, on their game plan will do that, because there's a lot of complicated patients that primary care can't do alone. They don't require surgery, but somebody has to do it. So there's not really a question in there other than to say I think that little piece of the continuum hasn't been spoken about much today, but I think it's critical for everybody converting or moving into value-based care, because there's a lot of waste that can be taken out if the proper physician who knows the disease the best is the one that's quarterbacking that care. And I was very happy to hear Kelly talk about the split in urology patients, where the primary savings goes to the person doing the primary work, primary care in the beginning, nephrologists after the fact. And then I just want to make one comment about Kelly. When she talks about going up to CMS and talking to them, I remember going up there in 2012, early on in the CMS process of ACOs, and we were supposed to give, I say we very loosely, it was Kelly and Hyman Zucker for the most part, we're supposed to give a presentation to 2 CMS representatives for 20 minutes. And it ended up being 20 CMS representatives for 2 hours. And the reason they all came in and stayed, everybody else that had come up, and they told us this after the fact, were they're complaining about the program. CMS wants to make it better, and everybody was telling them what they didn't like. We went up and told them what we did that was good and tried to find out from them, what did they hear from everybody else that we could incorporate? And I think that's the mindset that carries everybody forward. We just need to make sure that we're inclusive.
Lanny, you want to go to CMS again and talk about the thinkers? Because there's a space for the thinkers in this.
I would love to go. You set it up and I'm with you.
All right, we're going.
I think that's a great point. I think there's a big role for the thinkers. And I think it comes down the road, right? I mean, you don't even have the surgical specialists in the game yet. I mean, when I talk to everybody, nobody knows what I'm talking about at this stage. I have to explain them. As soon as I get to anti-kickback and Stark and there's changes, they don't want to hear another word. So somebody asked the question earlier, does that create an obstacle? There's been an obstacle there for 20-something years. And, anti-kickback is a criminal offense. So surgeons know that, and they don't want anything to do with it. But once you get surgeons in, and the surgeons are going back working with the primary cares, and then they have those referral bases are with much broader groups and much bigger, hopefully, surgical networks, then the next step to cut out care has to be the thinkers, because they're the other guys in the equation, and they have to come in and they have to figure out what can they do to help each group. And I know for a fact, primary cares and neurologists in the space that I'm in could certainly provide a ton of value for us. And we would share, the surgeons would share in that ability. And I think that probably plays out for most of the specialists. But I think it starts where it is, and then they come in. I think they're the next ones in.
So happy to hear you say that. You know what I mean? Like, because that is how it's going to come together. It's a process. But
Any
we're
other
working on it. For anybody out there watching, we're working on it. If you have any ideas, please send them to us, because CMS wants these ideas. That's what this whole program's about. And then whatever these ideas are, this is the 10-year plan, but we all know the commercial plans follow suit for Medicare, right? They take a while, they still do their fee-for-service, but this is just as important to them. They want to have their fixed costs. They want to know what their premiums are for the next 2 or 3 years. So this is important to commercial payers as well.
Any other questions? Where's her?
Are these the PCP side of the room?
I know she'll get the candy after.
Yes. So I'm actually a primary care physician. I work for a pretty large healthcare system down here in South Florida, and it's interesting to see this aspect of value-based care and the different perspectives. My question is, it is interesting looking at it from a primary care perspective in terms of the integration of working with specialists, and I would say that perhaps the biggest challenge is not necessarily teamwork, but also our EMR systems. How do you guys think perhaps the role with AI in helping sort of this collaborative effort from a value-based care perspective between primary care physicians and specialists, and how do you think that AI will play kind of a role in helping maybe create a improved EMR system for better coordination of care, better care delivery and integration? Because integration seems to be like the biggest challenge with an already fragmented healthcare system, just people talking to each other, they just can't.
I'll give a short answer because it'd be
Yeah.
great to get everybody's opinion, but I do think AI is going to be the answer. I think it can sort through millions and millions of notes, and it can pull those relevant points up depending on which specialty you are, the primary care. It can pull to your attention the 5 things you need to be thinking about, or you know what I mean? So it's a high value visit to the patient. Like, way back when patients would come in and you wouldn't even know they went to a cardiologist because they're fee-for-service patients. So they wouldn't see the PCP visit as a high. They saw their specialist, my cardiologist, my endocrinologist, my nephrologist, whatever, and the PCP may not even have known. Same thing with admits. Like, patients would come in and think that you knew they were in the hospital on the weekend, not talk to you about it until they were walking out the room, and they said, "Oh, by the way, I was in the hospital this weekend." You're like, "For what?" So I do think AI, it can sort through all these nodes, and it just can bring the most important things. And I just wanted to say one other thing that specialists can really help primary care with is transforming practices. Most people probably know all the coding changed from version 24 to version 28, and the specialists know what to do with that stuff, and they can help the primary care. So I think the AI is just going to take the really hard EHR, what do they call them, little bubbles or little candy things you're always checking every day long. It's just going to really make it nice and simple for you, I think, or at least that's our hope. Think ChatGPT on steroids for medical care.
Any other questions?
And I would say with, I'm a big believer in AI. I'm involved in a couple of companies. I'm the executive chairman of 2 public companies that are both developing new AI algorithms, one for diagnosis, the other one's in the technology space. But there's a ton that AI can do in this space. But AI is useless without good data. And you have to feed it and you have to train it. And that's the entire key. And to get to that good data, I think the biggest obstacle we have, I think it's HIPAA, right? I think just like we're sitting here at this conference, and this conference is opening up doors like Influence Healthcare could not exist without these value-based enterprise rules coming into play. You're never going to get interoperability of the EMR or good data about what you really want from that patient, I don't think, until you get rid of HIPAA. And then just think about the user interface you could have, that if every patient had this. I mean, I was talking to somebody here today about a thing that we wanted to start up one time called, and we aborted it because of HIPAA. But it was just basically everybody has an electronic record. It's called Timeline. And everybody has 5, 10, 15 different things in their life that are really important. Like, do I really care that you went to your primary care doctor last week and you got a flu shot? No, I don't care. But do I care that you went to the ER because you were in a motor vehicle accident and you had a head trauma 3 years ago? I care about that, right? So there's certain things in everybody's life that you want to see. So if the user interface is those 10, 15, 20 things, and then you can drill down on those and you have them in an order, like I know this happened to you last week or it happened 20 years ago, much different, right? But you can't get that data. You can't, a consumer can't get their own stuff. I mean, makes no
And
sense.
if the consumer had their own stuff, we'd get around HIPAA, right? So if the consumer was walking around with his own stuff and said, hey,
Exactly.
doctor, you probably want to see these 5 or 10 things. Sorry.
Yeah,
Just throw that in there.
The flip side, well, not the flip side, to your point, it's got to be the right data, it's got to be the right language models. It certainly wouldn't be something open like a chat GPT that might have an influence. I spent too much time in the cybersecurity space, and this is PHI we're talking about, this is protected data we're talking about, and you kind of flip over Jen Easterly, who runs CISA, which is the Information Security Agency out of the White House, says there are 2 things that keep her up at night: China and generative AI. So I think AI, generative AI is a little bit down the road, and now we've got a lot of machine learning, which is we got a lot where we can munge the data, but we're then going to have to control that data. And then for every opportunity under AI, there's a bad actor or a state-sponsored actor out there who would love to get a hold of your medical data, especially if you're, somebody of interest. And so it's just you got to temper it on the other side. So I don't mean to throw cold water on it. I think there's a lot that can be done with AI, but it's fraught with quite a few things.
Any other questions? Anyone? Okay, so to sum up this panel, Mike, come up. 50-year anniversary. Okay.
Maybe the time was wrong by a month.
Oh,
The truth
almost
is,
50.
My 50th anniversary is December the 3rd.
Okay.
So you can all send me congratulations on December the 3rd.
So I think in sum, to wrap it up, we've really have about, I'd say three or four key terms. Thinkers, or as Juliet said at the beginning, imagination, right? You need thinkers and you need people with imagination. You need them to then come up with a plan. And you need the data to support that plan. And then in the end, you need to educate. And those appear to be the components that will help push forward a lot of this integration. Is there anything else you want to add before we conclude?
I would just add collaborate. We've all got to work together for the better. So.
And I would add physician champions.
And I would just say, you got to do the do. Nothing happens without actually doing something.
Yep.
So, everybody's here doing something. So that's where it starts.
That's great.
So thank you for giving us the time and your expertise.
Thanks, Heather.
Thanks.
One of our attendees sent me about an hour ago, since hot off the press, that somebody filed a motion in the legislature in Florida to outlaw non-competes for physicians in Florida. I mean, that has a long way to go from filing a law and actually having it pass. But the fact that it's now there has an effect on a deal I'm working on right now. So we'll see what happens. But this is hot off the press, and it's really tending to evolve all over the country. I believe last year alone, I think they passed a law limiting non-competes in New Jersey, in Minnesota, I think, and maybe Indiana. So it's happening. And anyway, this is a fantastic panel, as were all the rest. Now I'm going to give you the information that you've all been waiting for. So hold on and get your pen out, because you'll never guess what the second word is after value if you want to get your credits. You're never going to guess. The answer is care. So, value care. So the secret's now out. Well, listen, it's been a fun thing we have. You're not over yet. You're done listening to us jabber, but back in the back we have a bartender, and you can have a drink or two, whatever you want. We're not going to tell on you. And so enjoy yourself and have a time to chat a little. And thank you for being here. We really appreciate it. And we appreciate our sponsors and all of you for participating. Have a great evening.